said, I'm Teresa Turner. I'm the stroke nurse practitioner at Alexian Brothers, and this is Megan, who works with our neurointerventional team. I know, a mouthful, and we can go into that more in detail. So we're here tonight to go ahead and discuss how to recognize and respond to stroke symptoms, and how to recognize and then also prevent. So again, hopefully we never get to see each other in person outside this library. That's the goal tonight. So the goals of the program are to identify the signs and symptoms of stroke, know how to respond urgently to the signs of a stroke, understand what a comprehensive stroke center is and the time-sensitive treatments that are available for stroke, and understand the risk factors for stroke, thus how to prevent stroke, and again, the updates on the newest advances in stroke care and recovery. So we want you to be stroke smart. So the goal, we want to reduce stroke risk, recognize stroke symptoms, and respond to the first time of stroke. Call 911 immediately. You're going to hear it again and again. The slogan is time is brain, because truly every minute the brain is deprived of oxygen, glucose, nutrients, cells die. So time is brain, time is brain. Stroke facts, so 795,000 people in the United States suffer from strokes each year. 610,000 of them are first-time stroke survivors, and within 5 years of those who survive stroke, 185,000 will go on to have a second stroke. Stroke is the leading cause of disability in the United States and is ranked as the second leading cause of death worldwide. Someone in the United States is having a stroke every 4 seconds, so every 4 minutes, someone dies of stroke. So in the course of an hour lecture here, we're going to lose how many of our friends? So the total cost of stroke. Stroke is very, very costly. The total stroke cost is estimated to be approximately $1.3 billion a year, and approximately $68.5 billion of total costs are primary costs, and secondary costs are from underemployment and premature death. Many of our friends, patients, co-workers cannot return to work after a stroke, and then we're stuck with long-term disability and the cost incurred with that. The age group of ages 45 to 64 account for the greatest cost among stroke survivors, again, because that's our demographic that's still working. So do you recognize stroke is out everywhere? People don't recognize that we have all these famous people that have had strokes. We've got Sharon Stone, we've got Gerald Ford, we've got, I'm drawing a blank on our friend here who had just had a bleed. Anybody want to help me? I'm having a little TIA. Anybody want to help me out here? These are all famous people that have gone on to have strokes that many people don't recognize. It's an equal opportunity offender, unfortunately. So what is a stroke? So a stroke is any time a blood vessel in the brain is disrupted of blood flow, either by a clot or by a rupture. A blockage or a rupture results in the brain not receiving the necessary oxygen and nutrients. The brain is very unique. It's the only organ in your body that doesn't store extra nutrients. There's no extra glucose, oxygen. So the minute that blood vessel is deprived of blood, everything on the other side is at risk of dying. That's why every minute counts. There's two kinds of strokes. There's the ischemic stroke due from a blood clot. The blood clot can be developed in the artery itself. Cholesterol and plaque develops over time, can close down an artery, or it makes a nice warm spot for a clot to form. It dislodges, travels down the brain till it gets to a vessel it can't go through. Everything on the other side is deprived of blood, oxygen, and thus the symptoms. Or it could be a clot that comes from someplace like the heart. Same idea. It dislodges from the heart, it's on the highway to the brain. We can also, ischemic strokes account for about 87% of all our stroke population. You can have a hemorrhagic stroke. You've heard about people who've had aneurysms. Strokes, these are strokes who have bleeding into or around the brain. And it accounts for about 13% of all strokes. So this is a little video we have.
Lauren was having trouble moving, and her speech was slurred and face drooped. A stroke seemed so unlikely. She was only 30. I had to react immediately. I called 911, and Lauren quickly received medical attention. Now we don't take anything for granted, especially spending time together as a family. Looking back, I'm so grateful I didn't hesitate to call 911. A quick reaction can make all the difference. Learn signs of stroke. Visit strokeawareness.com.
Like I said, unfortunately, stroke's an equal opportunity offender. It doesn't care about your age, your demographics, your sex. It can hit any of us at any time. So stroke symptoms, everything with stroke is sudden. It hits the sudden onset of a severe headache. People say it's like the worst headache of their life. Sudden numbness or weakness on one side of the body, an arm, a leg. Sudden confusion, sudden trouble speaking or understanding speech. Patients will say, family will say, they're speaking gibberish, I don't understand them. Or you'll ask them to do something and they can't understand what you're asking them to do. Sudden trouble seeing in one or both eye. Patients will say it's like a curtain being drawn over just a field of their vision. Sudden trouble walking, dizziness or loss of balance or coordination. Going to reach for a cup and they just can't make contact with it. The loss of balance where you're surfing off the walls to get yourself to the bathroom, things like that. Again, or sudden severe headache. Once again, time is brain. Anytime you have any of these signs and symptoms, 911, be fast, every minute counts. Again, be fast. This is the acronym we use in our EMS region. Balance, sudden problem with balance, walking or dizziness. Eyes, again, sudden loss of vision, blurry vision, double vision. Face, look for an uneven smile or grimace. You have them smile and one side of their mouth is drooping. Sometimes they'll be drooling along with it. Sudden arm weakness. Have them lift their arms. You'll see patients, we call it a drift. They can't keep one arm up. Sudden confusion, trouble speaking or understanding speech. Ask them to say a couple words to you, a couple sentences. So often they won't be able to recognize the person they're with. They couldn't get Megan's name out. And again, every minute counts. Time is brain. I know it seems so common sense, but you have no idea how many. I had a patient today who actually woke up and an arm wasn't working at all. Not at all. He went to urgent care. Of course, they called 911 and brought him to us, but he wasted all that time going to urgent care. You know how you wait in the waiting room kind of thing. You know, he said his arm hurt. Well, it was weak. He had absolutely no use. So again, time is brain. When in doubt, get to the hospital. So a trans-ischemic attack, that's a misnomer. So in the old days, we used to call these mini strokes. And mini stroke means if you had a stroke, that means there's been damage done. So we took away the term of mini stroke, and now we use trans-ischemic attack. It is a sign of an oncoming stroke. It's the same etiology. A blood vessel is blocked of blood. Everything on the other side, we said there's no nutrients stored in those tissues, so you get symptoms. Cells are struggling to live and die. But the body's amazing, and they're able to flush that clot out, and the symptoms dissipate. Up to 40% of patients who have a TIA will actually go on to have a future stroke, so it's kind of a warning sign, don't ignore it. Symptoms are exactly the same, all the same symptoms, the weakness, the numbness, the difficulty of speech. The symptoms just resolve within minutes or hours. Seeking immediate medical attention is important because, again, we want to go ahead, find out what caused this, prevent a stroke from occurring. So what is a comprehensive stroke center and the treatments that are available for stroke? So a comprehensive stroke center, Alexian Brothers, is a comprehensive stroke center. That means it offers the highest level of complex stroke care 24/7. So if you came to Alexian Brothers, you went to Northwestern, you went to Rush, we're all able to deliver the same level of stroke care. We meet rigorous standards set forth by all the regulating bodies, the American Heart, American Stroke Association. So the guidelines we follow at Alexian, again, are universal. We're not making them up as we go. Everywhere you go follows the same exact guidelines set up by these two associations. And we have a very detailed, rigorous certification process with the American Heart, American Stroke Association and the Joint Commission. So patients who receive care at the Comprehensive Stroke Center have better outcomes because we have everything in our stroke toolbox to offer them. Again, I'll go ahead into all that. So again, emergent time, everything's don't stall, make the call. So things we have in our stroke toolbox. Stroke toolbox, as far as we've come in stroke care, is still pretty limited. So we have two things in our stroke toolbox. We have a super duper clot busting medication, something called TNK, tenecteplase. That can only be given within 4.5 hours of last known normal. So what does that mean? The last time you were 100% in your normal state of health. I can give that medication. That really limits you. If you went to bed at 10 o'clock in the morning, at night, and you woke up at 6 in the morning, you're already out of that window of opportunity. So that's out of my toolbox arsenal. I can't use that. The second thing we have at Alexian Brothers, we're a comprehensive stroke center. We have something called a biplane suite. It's we'll be able to do this very complex procedure where the physicians, Megan and her team, actually go in there under a nice little general anesthesia. They were actually like a cardiac catheterization. They're able to put a catheter in the femoral artery, and under X-ray and radiation and dye, they're able to go ahead and thread that catheter up into the brain to get to that clot itself. And then they have the capability with many different devices to either suction it out. We can use a stent. The goal is to remove that clot to promote blood flow back to that area that's been deprived of blood. We also have the ability here for patients who have subarachnoid hemorrhage. Everybody heard of aneurysms that bleed? They have the capability under the same mechanism in this biplane suite to go in there through the groin, not through opening your brain, not through complex surgery. If it's amenable, the doctor can actually go in through this catheter, find the ruptured artery, and the aneurysm is just an outpouching of an artery, and they can actually fill it with coils to close it off. Before, we did not have that in our stroke toolbox. We would have to actually go in and do complex brain surgery, removing the brain, manipulating brain tissue, healthy brain tissue, to get to the damaged artery. So we're able to do that at Alexian Brothers as well. So again, we have complex treatments, procedures, and surgery for hemorrhagics as well as ischemic strokes. So people don't recognize strokes. Yep, nearly 1 in 3 adults in the United States do not know the common signs and symptoms of stroke. I just told you about the gentleman who woke up with an arm he literally had to drive with the other arm because the right arm was not working at all. It did not even dawn on him that this could possibly be a stroke. Denial, again, patient who wants to have a stroke. And strokes don't hurt. That's the deceiving thing about it. You have a heart attack, it's painful. You're short of breath, you have crushing chest pain. Stroke doesn't hurt. That's the thing about it. They think nothing can be done. We have these things in our stroke toolbox. They think the symptoms will go away. Again, my point and my gentleman today who went to the urgent care without an arm working. Fear or trust, they don't understand or trust hospitals. Dr. Google, I can't tell you how many people say they Google. Yes, please.
You were talking about locations before, and you were talking about those comprehensive centers. So a lot of these hospital, so you were talking before about the hospital locations,
yes,
comprehensive locations. So a lot of these hospitals have satellite offices. Mm-hmm. And so when you say comprehensive, that would be just like the big hospital, right?
Okay, so a comprehensive stroke center, we are saturated. We're lucky here in this region. We are saturated. So we're a comprehensive stroke center. Northwest Community is a comprehensive stroke center. We have Lutheran General, we have CDH, we have Resurrection, we have Edwards, we have a lot. But if you happen to go to a Glen Oaks or to a St. Alexis, what they do is they have the capability, all these hospitals in our locations have the capability to give this clot-busting medication. So we give the medication if you're a candidate, and then we ship you out, either by ambulance or air, to the nearest comprehensive stroke center. So we have a whole triage team. We have like a hotline where another hospital calls our hospital. The doctors go ahead, look at imaging. They say, yes, indeed, this patient is a candidate for advanced treatment. Send them over. So lights and sirens, or in a helicopter if needed. They get there. The team is waiting. We meet them at the ER door, and we start our procedures there.
So, for example, and you have that office on Gulf Road. So
None of this is office-based. This is all hospital-based. So if you went to an office, they would go ahead and send you to the nearest hospital.
Okay.
Yeah. Unfortunately, you can't decide what hospital you go to. Unfortunately, EMS has their own routing, so EMS has to take you to the hospital that they're designated to go to, and then they will go ahead and triage you to the next appropriate level if necessary.
And then you say minutes, but you also mentioned a 4-hour time period. Okay,
so 4.5 hours is the time we can give you that super duper clot busting medication, something called tenecteplase. But it's very time limited. The studies show that if we give it over this 4.5-hour window, you're at more risk of bleeding than actually we can do more harm than good. A stroke is like a fresh scab on the brain. So cells are dying as we speak. And if we go in there and give this super duper clot busting medication, we worry about patients bleeding into their stroke. So we have very finite limits. And this is a worldwide limit. 4.5 hour is not just a United States FDA approval, it's a worldwide recommendation. That is the hard cutoff for tenecteplase.
Okay, thank you.
Absolutely. So stroke prevention. So we talked about all these things. My goal is to never have to meet you in the hospital. So is stroke preventable? Absolutely. About 80% of all strokes can be prevented through risk factor management. So modifiable risk factors and non-modifiable. I always tell my patients, can't make any younger, can't change your gender, can't take care of bad family history or prior stroke, but we can control your high blood pressure, we can control your diabetes, your high cholesterol, get you moving. Limit your alcohol intake. Atrial fibrillation, which we'll go into more, is a big risk factor for stroke. By controlling these, we reduce our risk factor for stroke. Again, prevention, blood pressure. Blood pressure, high blood pressure is a direct linear correlation with ischemic stroke. So know your blood pressure, get it checked annually. If it's elevated, work with your doctor to control it. Doctors never just go in there and treat one isolated blood pressure. You know, some people get white coat syndrome, you go in there and your blood pressure is artificially elevated. So they usually have you take multiple blood pressures, but keep a log if you're in doubt. You stopped at Walgreens, got your blood pressure, oh my gosh, it's elevated. Keep a log. Try to take it the same time every day, keep a log, and then bring that to your physician. It helps guide them and makes the decision tree a little easier as far as what kind of medications. Atrial fibrillation. So atrial fibrillation is an irregular heartbeat. It is the most common irregular heartbeat in elderly. Irregular heartbeat, normally the heartbeat's in a beautiful symphony. Atrium, ventricle, atrium, ventricle. With atrial fibrillation, there's a short circuit in electrical activity of the atrium. And it doesn't pump, it quivers. And I always tell my patients, think of it as an ineffective sump pump. All the blood doesn't go to the next chamber. Anytime blood sits and pools, clots can form. And then those clots are on the highway to the brain. So again, your doctor, and I've had patients, unfortunately, you go into your doctor, you get a 12-lead EKG every year for your physical. It's normal, right? It comes back fine. It's a sneaky little bugger. It comes and goes. If you feel yourself having a regular heartbeat, fast heartbeat, I've had actually a couple patients, I've had 2 patients, including a friend, who their Apple Watch caught atrial fibrillation. Don't discount it, get into the hospital, let us do it, let us evaluate that. Is a big risk factor for stroke, and it's something we can easily manage. And then smoking. If you smoke, stop. If you are smoking, stop. If you're not smoking, don't start. So smoking is bad because it not only changes the lining of the blood vessels, makes it a nice warm spot for cholesterol and plaque to build up. It also causes constriction. It causes those arteries to narrow down. So you're doubling your risk for stroke. Diabetes, if you're a diabetic, follow your doctor's recommendation, controlling your diabetes. They have all these new drugs on the market, Ozempic and Mounjaro. There's also the metformin, tried and true. Again, keeping your A1C under control. Cholesterol, knowing your cholesterol. Work with your doctor to keep your cholesterol down. Diet and exercise. Let's be realistic here. If you have never been in a gym before, you're not going to start now. Just walk. Just a body in motion stays in motion. Walk. Walk the mall, walk the grocery store, just move. People unfortunately get intimidated by the lofty idea of exercising. Just move. Again, risk factors we can't control: age, gender. Stroke kills more women than breast cancer. Sorry, twice as many women every year than breast cancer. Believe it or not, people don't realize that. Breast cancer gets a lot of press, but stroke does not. More women than men die from stroke because we live longer, sorry gentlemen. And the risk is higher for women due to longer life expectancy. But unfortunately, women suffer greater disability than men. Ethnicity and race, we know that African Americans and Hispanics have a greater risk for stroke than Caucasians. Part of it is due to risk factors and access to health care. Part of it is also genetics. So the 3 R's to remember of stroke: to reduce it, reduce your risk of stroke, recognize the signs and symptoms of stroke, and respond immediately. Stroke is a brain attack. It's preventable and treatable. Call 911. Every minute counts.
Is sugar a risk factor with stroke?
Well, that's what diabetes is. So again, if you've been to your doctor recently, you know, again, we never really follow one isolated blood sugar. So we have something now called the hemoglobin A1C, which relatively new in the health world compared to, I've been in medicine for over 40 years, so relatively new, let's see that. But the hemoglobin A1C gives you an idea of what your blood sugars have been running for 3 months. That's what the doctors like to see. It gives us a trend, so we can understand it, because one day your sugar might be here, one day it may here. It kind of gives you an average of what your blood sugars have been running over the last 3 months, and we like it to be below 6%. You're welcome. Okay, so now we're going to go into the recovery and treatment. So stroke timeline. So we have our stroke occurred. We talk about that sudden onset, boom, symptoms came. The hyperacute, the first 24 hours, that's when we need to get in there. That's when we have the most chance of making an impact on stroke interventions and recovery. The acute phase is the first week. Early subacute, 1 to 3 months. Late subacute, 3 to 6 months, and then chronic 6 months. Stroke recovery happens over a period of time. Stroke is worse in the beginning, and they get better over time. It's about we'll see the greatest recovery in probably the first 6 to 12 weeks, but patients continue to recover for 6 months out. The progress is just a little slower at that time. So hyperacute, again, we talked about that. The brain is weird. It's the only organ in the body that can't store extra nutrients. So the minute that vessel is closed off, everything on the other side is deprived of oxygen, glucose, nutrients. Some cells will live and some cells will die. The goal is to go ahead and open up that blood vessel to reestablish blood flow to that area. During the first 7 days, we might see a rapid improvement or little improvement, depending upon the amount of cells returning to basic function and therapies initiated. Stroke is all about location. Some patients will always say, was it a big stroke or a small stroke? For me, it's all about real estate. You can have a small stroke in a very important part of your brain and have devastating deficits. Or you can have a large stroke. Believe it or not, there are a couple areas of your brain that are redundant, and you will do great and recover fine. So stroke is all about location. It's all about real estate. I think we go back, yeah. The late subacute is 3 to 6 months. Some of the neurons, the brain is, so people have a heart attack, same idea, tissue dies, it's done. The brain has this great ability to help rebuild structures, to rebuild neurons and pathways. It's something called neuroplasticity. One side of your brain will realize, hey, this side's not working, and will help go ahead and take over some of that function. That takes anywhere from 3 to 6 months for those pathways to reestablish themselves. And then 6 months beyond, at this point, the neurons can be working efficiently. They can be slow, maybe a little work shy, still trying to develop these reconnections. This means that spontaneous recovery and improvement is slow at this point. Unfortunately, again, it's all about location, but young, healthy brains are full and active. As we get older, everything atrophies, our muscles atrophy, our brains atrophy, so we have a little less brain tissue to recover. So the chronic phase, so once we're in the chronic phase, which is 6 months or greater, the brain is settled into this new state of neuroplasticity. There's no longer peaks and valleys like there was in recovery. The neurons are slow to reestablish these connections. And then I'll tell you about, so in 2021, we have a new study that was published that highlights the brain's ability to make these new neuron connections when there's a vagus nerve is stimulator. So it's a small stimulator that's implanted on patients who have disabilities with the arm or hand. 6 months out, before we had nothing really in our arsenal again, this is something that patients who have weakness in an arm or hand now have the ability for this new device. Medicare just passed this, everything gets tied up insurance, as we know, pre-authorization, anything new, we're handcuffed. It's so frustrating as a provider. But in 2023, Medicare passed a new code that's really encouraging these new technologies because there's so much coming on the market. And our FDA is a little slower than the European market, for good and for bad. So now we have a new device that's come on the market. It's called Vivistem. Vivistem is a breakthrough treatment designed to help increase neuroplasticity in the patient. That's, again, the brain's ability to establish these new neurons, connections, and help patient regain 2 to 3 times more hand and arm improvement versus rehab alone. So we wait for that 6 month because the brain has kind of exhausted its resources at that time, see what deficits are left, and then patients are evaluated for this. So during rehab exercises and at-home activities, Vivistem is activated to gently stimulate the brain through the vagus nerve. So they actually put a small device into the chest here, attach it to the vagus nerve, and provide stimulation to the vagus nerve. This actually gives the brain a little boost to help strengthen and create these new neuronal connections to bridge the bypassed area. Again, that area is dead. There's nothing working in there. The goal is to provide neurons from one side of the brain to the other to help reestablish connections. It's designed specifically for patients with ischemic stroke survivors who are at least 6 months, post-recovery with upper extremity limitations. So far, it's just been used for upper extremity. Yes?
So this is an implant?
It is. It's an implant, exactly. So it's an implant that is put, so you have to, after 6 months out, if you have some weakness left, residual weakness in your right, or an arm or hand, Vivistem does an analysis of your brain and decide whether you're not a candidate, and then they actually put a small stimulator into the chest here, and they go ahead and attach almost like a pacemaker, but it stimulates the vagus nerve. Vagus nerve is one of the key nerves in our brain, and by going ahead and kind of giving it a good shock, we're going to boost its energy to help reestablish new connections.
So is it permanent?
It is. Yes, it is a permanent device. It is a permanent device.
So it is an implant and it's permanent?
Yes.
Implant.
It is permanent implant, just like a pacemaker or anything else, exactly.
Do you need to check it every so often?
You'd have to, once you qualify, I'll be honest with you, I don't work directly with the Vivistem. It's an outpatient procedure, so I'm not sure. I'm sure they do. I'm sure they monitor frequently, things like that. But I don't know enough about it to give you that information. Yes, absolutely. Mm-hmm. So again, this is a patient who had a stroke, who had lost control of her right hand and was unable to write. So you can see the before. It's basically just scribble. And then 3 years post-stroke, we're going to go out from there. So 3 years post-stroke, she still has this pretty profound deficit. 2 weeks after the Vivistem is implanted, we'll go ahead and stimulating that vagus nerve, hoping we're going to recreate those neuronal connections. You can see it got a little bit better by 5 weeks, and look at 8 weeks. It's pretty significant. Before, again, our stroke recovery toolbox is also expanding. Okay, yes?
Why does it only work on the arms?
That's all that's been established for by the FDA so far. Yeah, I think they're starting small and they'll work their way up.
If anybody needs the money.
Yes?
Could somebody have a
Just a moment.
ministro?
Just a moment.
Can someone have a mini stroke such that there are no BFAST symptoms?
Okay, well, let's clarify that. So a mini stroke is a TIA. Is that what you're talking about? When you have a stroke means there's been damage done to the brain. So if I do an MRI, I'm going to see a scar on your brain. Okay, you may not have symptoms left over. A mini stroke is an aborted stroke. We call that now a TIA, a trans ischemic attack. Yes, and unfortunately, there's a weird group of stroke symptoms that aren't often caught. Patients have dizziness, blurred vision, loss of balance. So that vertigo mimics that. So we have a very complex screening tool that we use when patients come in to go ahead and decide, and when in doubt, so we have a whole stroke alert process at a comprehensive stroke center. So if you come in and we're worried about stroke-like symptoms, we go ahead and we start this, we call a stroke alert. Everybody stops what they're doing, clears the table, team collaborates. We take you directly to the CT scan. We get a CT of your head. CTs are great, they show us bleeding, but small strokes never show up. So I just want to rule out bleeding. Because if it's bleeding, I'm calling my neurosurgery friends, I'm excusing myself. But we always do a CT angiogram, which is where we inject dye to look at the arteries of the head and neck to see where that stroke might be located. So again, there's a small group of patients that have the signs and symptoms. They're obscure. Like I said, I have vertigo, scares the heck out of myself a couple months ago where I couldn't get out of bed. The dizziness was so profound, and nausea and vomiting. I gotta tell you, I did my own stroke scale at home. It's concerning. I mean, it really is. Those are the very few, but most of the signs and symptoms that we said are very noticeable.
And so let's say, based upon this presentation, we now think, oh, maybe something that occurred to me like this, let's say weeks ago, but there are no other obvious symptoms. So what would you advise then, if somebody goes to the hospital and has one of these tests?
I would advise you to go to your physician. Based on your risk factors, he can make an assessment and go from there. A lot of these tests, if you had a transischemic attack, a lot of these tests can be done as an outpatient, absolutely. So in the moment if you're having it, do not wait, because I don't know if that mini stroke is going to turn into a real stroke, if that transischemic attack is not going to abort. The body's not going to be able to compensate, and then you'll have a full-blown stroke. So if you're having these symptoms, do not wait, get there. In retrospect, you have no idea how many times patients come in, they'll say, you know what, I woke up and my hand just didn't feel right. Oh, I thought I slept funny. In about an hour, it went away. In retrospect, that was a TIA, and they ignored it. So again, if you have any of these things that are going on, go and talk to your physician about your risk factors, and they can do a complete risk factor analysis. High blood pressure, cholesterol, diabetes, checking for atrial fibrillation, all those things that make you at risk to have a stroke.
Okay, thank you.
You're welcome.
I have a question.
Yes.
You mentioned vertigo and balance.
Yes.
That is pretty common in the older generation.
Absolutely.
How do they know, in case they're not sure, is there any way for them to know, oh, this was just a vertigo or lack of balance and not a stroke?
If you have chronic vertigo, then it's most likely still vertigo kind of thing. But if it's a new event, sudden onset, then I would definitely come and have it evaluated, absolutely.
So what other symptoms from that BFAST you think would be part of the symptoms that would give them an indication?
Just the balance, the balance, the dizziness and the balance. The patients who can't, you're literally bouncing off the walls, you can't grab a cup, we call it ataxia kind of thing. Those would be the things. When in doubt, come and see us. I'd rather send you home and say you have a clean bill of health than wait and I have to meet you in the ICU. Anything else I can answer? Okay, if something comes up, I'll still be here. Any questions from Megan? Megan's actually with the team that does the interventions, the thrombectomy, where we take you to that very sophisticated biplane suite, and the doctors can actually go into the brain and get the clot out, or they actually can go in there and close up the aneurysms. Megan works with that team.
Yeah, I've seen these, like, they almost look like a camper, but it's a stroke.
Can I just-
What is?
So the mobile stroke unit, I have mixed feelings about that. The whole,
Repeat the question.
yeah, so she was asking about the mobile stroke unit. She's seen that at NBC. It's a really long truck that has stroke equipment in it. So they actually have the capability to do a CT scan, nothing more, just a CT scan. In the scanner, they have communications with a physician and a team who could look at the imaging. They can give that clot-busting medication right there in the scanner, and then they have to transfer you to a comprehensive stroke center for a further evaluation and workup. It's great because time is brain, if that's the thing. Mobile stroke units are of great resource in the urban areas, like down in southern Illinois, where we just talked about all the hospitals. Look, I can name right in this little area all the hospitals, we have either primary or comprehensive. Down in the fields of, Southern Illinois, they don't. So that is of great value for them. Get them in there, start the medication, start the triage while they're transporting. So Central DuPage has one. That's the one you probably see local. They do come, they run somewhere with our Region 9 EMS. So everybody's got their own region. And then Rush used to, and I don't know if they still do. That's the only one in the metropolitan Chicago areas. Yes.
Is stress and anxiety a risk factor?
So she asked, is stress and anxiety a risk factor? Well, stress and anxiety increase your blood pressure. It might affect your diabetes. Things like that. In and of themselves, no. I think we all probably have strokes, right? But again, if you have underlying risk factors like high blood pressure, diabetes, things like that, things that affect your risk factors are definitely then affected. So again.
Just a quick reminder, please raise your hand up. Let me bring you on the mic. It will help in case you all have to review the recording. That is what this is for. This records what's.
Do we still talk about having the TNK within the first hour?
4.5 hours. 4.5 hours.
When it's select, but
Yes.
I recall us talking about talking about within the first hour you have maybe 75% recovery, and then the second hour 50%, something like that. Do we still talk about that?
I don't know the exact number, but you're correct. We talked about that. So you have a blood vessel that's been blocked of oxygen. The area immediately after that is dying. By the minute, you're losing cells by the minute. The area around it, we call it the ischemic penumbra. It's hurting. There's still some little extra collateral, we call it collateral, little valleys and streams that are feeding that, but it's not enough to keep those cells alive. After a while, the demand on those little arteries is too much and they collapse. And then that area around is at risk of dying. So again, that's why every minute counts. Again, it's called the ischemic penumbra. So you have the death of tissue, the area around it is rather stunned. It's trying to live and die. Your body's trying to compensate with all the other arteries, trying to shift a little more blood to that area. But over time, it can't compensate anymore. And then those tissues die, those cells die.
Okay, we are going to move on to the second part of our presentation.
Okay, perfect.
The nutrition part.
Thank you.
Alrighty guys, so good evening. My name is Daria. I'm a registered dietitian. I have been a dietitian for about 5 years now, and I've been with Ascension for about 1.5 years. So I'm here to talk to you guys today about how we can use the Mediterranean diet, which I'm sure you guys have heard of, to stroke-proof your life. How can we utilize it to help prevent a stroke? So before we get started, I want to play a little game with you guys. We're going to play true and false. So you guys can go ahead and shout out true or false to the questions that I ask, okay? So the first question here is, true or false? Whole grains can help reduce LDL cholesterol and improve your blood sugar. Okay, good. That was true. Second question, true or false? Olive oil is high in saturated fat. Wow, you guys are good. You guys are so good. All right, so the next one, true or false? Drinking more red wine will make your heart healthier. I really thought I would get you guys with that one. So this one is actually going to be false. And we're going to talk more about why that is, but this one's going to be false. Drinking more red wine will not necessarily make your heart healthier. Okay, so more on this later. But very good job. I'm very shocked that you guys got all of these right. Now, just a little bit more about me. I, like I said, have been a dietitian for about 5 years. And I have a strong passion for helping people with diabetes management, which did get brought up in a few of the questions that you guys had asked. Diabetes can certainly affect your risk of stroke. So we definitely want to make sure that we are not getting diabetes. And if you're interested more in learning, I do also have a blog. You guys can grab a handout on the way out to learn a little bit more. And Just a few more fun facts. I'm a cat mom. I love cats. I'm a first generation college student and graduate. My parents are Polish. And I love coffee. I cannot live without coffee. Okay, so let's now talk about how the food we eat affects our risk of stroke. And I have a short video here to demonstrate that for us.
The heart pumps blood to the body through a complex network of arteries. With exception of the coronary arteries, which nourish the heart itself, most arteries transport oxygen-rich blood away from the heart. Circulating in the blood are red blood cells, white blood cells, nutrients, and other life-sustaining substances. Cholesterol and other fatty substances also circulate in the blood. Over time, these substances can be deposited in the artery walls, a condition called atherosclerosis. The deposited cholesterol, or plaque, can build up over time, causing hardening and narrowing of the otherwise smooth artery walls. When the walls of the artery become narrowed and hardened, blood flow is restricted. As the plaque accumulates, the buildup can become unstable and may break off or rupture. A condition called thrombosis results when blood starts to coagulate or clump together at the site of the rupture, similar to the way blood clots to stop bleeding from a cut. The blockage or thrombus can grow larger, further restricting the flow of blood. The thrombus is also in danger of breaking from the site and traveling through the arteries. The blockage caused by a thrombus can be life-threatening. A blockage in the coronary arteries may cause a heart attack, while blockage in a cerebral artery may cause a stroke. Blockage in one of the major arteries of the body can prevent blood flow to an extremity or organ, causing pain and tissue damage to the area.
All right, so that video did a really good job of showing us how that blood vessel gets much smaller when that plaque develops. But how does that plaque get there? Diets that are high in saturated fat, diets that are high in added sugar, and diets that are high in salt can make that blood vessel weak, causing that plaque to form. So a diet that's high in fruits, vegetables, whole grains, beans can help reduce that plaque formation and help stroke-proof our life. So what exactly are the benefits of the Mediterranean diet? First and foremost, we talked about blood pressure, right? So the Mediterranean diet is naturally lower in salt. It focuses on a lot of plant-based items, like we said, fruits, vegetables, whole grains. It also helps to reduce our risk of heart disease because the diet is naturally lower in those bad saturated fats. That diet also helps to lower your LDL cholesterol. So think of the LDL cholesterol as trash, right? It's in the arteries, it's clogging the arteries, and our good cholesterol, our HDL, helps to kind of act as a garbage truck and takes that out of our blood vessels. So the Mediterranean diet helps to naturally lower that LDL or trash. Now moving on to blood sugar improvements. The Mediterranean diet is naturally going to be lower in those high glycemic foods. So low glycemic foods, again, fruits, vegetables, whole grains, and beans are going to be much healthier for your blood sugar. The foods that are included in the Mediterranean diet are also lower in calories. So if we're consuming less calories, we are able to manage our weight and prevent weight gain that also causes issues with our blood sugars and high blood pressure. And lastly, and I think most importantly, it helps your overall well-being. It's more of a pattern or a lifestyle rather than an actual diet with rules and things that we have to follow every single day, right? It's also flexible. So the fact that we can change it according to our own preferences and individual cultures, right, is super important, and it helps with consistency long term. So where does exactly the Mediterranean diet come from? Because I'm sure you've heard Greece and Italy come to mind when we talk about the Mediterranean diet, but it's actually made up of 21 different countries. There's 4 different regions here. You'll see the North African region, you'll see Greece and Italy, of course, like I mentioned, but you'll also see France and Spain, Turkey, Syria. So all of these very cool cultures impact the foods that are included in the Mediterranean diet. Now, the Mediterranean diet was coined in the 1950s in a 7-country study, and it was the first study to link diet to chronic disease risk on a global scale, which is huge, right? It's basically saying what we eat directly impacts our health. So now we've talked about the benefits. We've talked about where it comes from, but what exactly is the Mediterranean diet? Like I said, there's no specific Mediterranean diet. There are a few core principles though. So a lot of fruits, vegetables, beans, whole grains. That's the basics. You'll see that olive oil is the primary source of fat. So like we talked about at the beginning, olive oil is a very heart-healthy type of fat. The Mediterranean diet is also going to focus on low to moderate intake of dairy, eggs, fish, and poultry. So not completely plant-based, but it's heavily plant-based, okay? And it can vary from individual to individual. If you are not willing to go completely plant-based, that's okay, right? Nobody's forcing you to eat beans and legumes all day long, but we certainly want to start incorporating more of those foods in the diet. And I'm sure you're wondering about the wine, right? So the Mediterranean diet does include wine. 1 3.5-ounce glass for women a day and 2 for men. As far as lifestyle factors go, again, this is more of a lifestyle than a diet. So we want to encourage regular physical activity, having social meals with your family, your friends, and this in turn will help lower your levels of stress, which someone had asked earlier, right? Stress can affect your blood pressure. So if we can utilize exercise and eating with family and friends to help us manage that, I think that's awesome. And I definitely encourage that. Okay. Any questions so far? Oh, wonderful.
My question is that when it comes to chocolate, is dark chocolate actually healthier than milk chocolate?
So dark chocolate is going to be lower in added sugar, and it doesn't have as much dairy, right, like milk. And milk tends to have some of that saturated fat in it. So yes, I would say dark chocolate is probably your healthier option, but of course, moderation is key, right? If you don't like dark chocolate, don't force yourself to eat it. Eat less of the milk chocolate.
Okay, the second question is about coffee. Is there any helpful difference between dark roast, medium roast, or light roast?
As far as the health benefits, I'm not too well versed in that. But if you're looking for more of a caffeine kick, the blonde roast is going to be typically like a more caffeinated choice.
Thank you.
Okay, any other questions? Okay, so now let's talk more about how the Mediterranean diet actually helps us prevent strokes. So you'll hear me keep saying fruits and vegetables, which a lot of us lack, but this is the basic foundation of the Mediterranean diet. And that's because it has fiber, it's got antioxidants, and it's got phytonutrients that help to manage those risk factors that Teresa and Megan were talking about. So first and foremost, fiber. Fruits and vegetables are the best source of fiber. And fiber helps to lower that bad LDL cholesterol. So again, remember that trash that's in the blood vessels, fiber helps remove that. Fiber prevents your blood sugar spikes. And that blood sugar, if it's high, can damage those blood vessels and make them more susceptible for more plaque forming. Now, what is really cool about fiber is that it also helps to produce a substance in your gut that helps to open up those blood vessels and decrease your blood pressure. It also helps protect the brain from harmful substances. So lots of benefits here, and we are not done. So antioxidants are the second part of intaking fruits and vegetables in your diet. Now, antioxidants are substances that help to fight off damage in the body. So think of an apple browning, right? When you cut the apple, you expose it to oxygen and it turns brown. So your cells, when we have oxidation going on, there is damage to the cell. So antioxidants in fruits and vegetables prevent that damage, and if you want to call it anti-aging almost, right? Your cells are going to stay the way that they were made, and it's going to preserve their function and their structure. Antioxidants also help reduce inflammation. Phytochemicals are also very similar to antioxidants. So these are natural compounds found in plants that have a protective effect on your body and your brain. They support new brain cell growth. So when we have a stroke, like the ladies mentioned, that it's slower at the beginning, right? I'm sorry, it's faster at the beginning, and then it slowly gets, the progress gets slower, right? So having more of these phytochemicals supports new brain cell growth after a stroke. They help support lower blood pressure, again, fighting the damage from your cells, and also supporting your immune system. So for example, vitamin C, that's found in oranges, bell peppers, broccoli, beta-carotene, found in carrots and sweet potatoes, anthocyanins in blueberries and strawberries, curcumin in turmeric, and of course, resveratrol in red wine and grapes. So there's no specific fruit or vegetable that we would recommend on the Mediterranean diet. The key here is having color on your plate. So here I have listed a few that are most commonly seen on the Mediterranean diet, but of course there's more than these. So berries get a large, attention in the media because they do have a lot of those antioxidants and phytochemicals. But again, pomegranates, apricots, Brussels sprouts, kale, beets, there's a plethora of extra ones that I have not listed here, but are certainly also welcomed. Now here is just a diagram further showing you how that fiber in fruits and vegetables helps to get rid of that cholesterol and plaque in your blood vessel. And here it shows you how that fiber helps produce a substance that dilates your blood vessel to decrease your blood pressure. Any questions so far?
I might be jumping the gun.
That's okay.
The one thing that's sticking in my brain is lower the chicken, the fish, the dairy,
Mm-hmm.
And I'm thinking, how are we getting our protein besides the beans?
We're gonna get there. So I can answer it now if you want, but I have a whole slide on that. So we're gonna get there. Sure.
I have a question regarding the fiber. Can we take too much fiber? In the sense, do we use nutrition if you're eating too much?
Yes, there can be a point of too much fiber. Now, for women, we typically recommend about 25 grams of fiber a day. And for men, it's a little higher, about 30 to 38. Now, everyone is different though. Some people need a little more, some people need a little less. Because every body reacts differently to fiber, right? Because fiber also makes you go to the bathroom. So if we have too much or too little, it can cause issues in that regard as well.
You're talking about soluble fiber or mixed?
So soluble fiber and insoluble fiber, they're still fiber in general. So when we're, let me repeat your question really quick for Sangeeta. So the question was if I'm talking about insoluble or soluble fiber, correct? Okay, so when we're talking about fiber, there are two kinds, like you said. So in this term, we're talking about both insoluble and soluble. They are both going to be beneficial for the heart health and stroke proofing your life. Does that help? Okay, good. So let's talk about whole grains. It's recommended to consume these daily on the Mediterranean diet. And the reason for that is they provide the fiber that we just talked about. There's B vitamins for energy production, vitamin E and selenium, which help to prevent that oxidation. So they act as antioxidants. And some have protein. So whole grains are a good source of protein, especially as we age, because we typically don't get enough. So whole grains can absolutely be a source of protein if we're using the Mediterranean diet. Now, if you take a look at this picture here, on your right, you'll see the refined grain. So this is like your white pasta, your white rice, processed products, cookies, crackers. They're often refined. It does not include any of that fiber, no vitamins, no minerals, all of that has been stripped. And you'll see that on the left, the whole grain, it's got the bran, it's got the endosperm, and the germ. So it's including all of those nutrients, and that's what we want if we're looking to reduce our risk of stroke. Now I want to highlight here the vitamin E, because the vitamin E acts as an antioxidant and it helps those clots from forming. So remember those clots that we saw that travel throughout the body and hopefully not to the brain, but it can, right? That will help to prevent that from happening. Same with selenium. Vitamin E and selenium work together in that regard. I've also mentioned omega-3 fatty acids here. And we're going to talk more about them in just a moment here, but omega-3 fatty acids specifically work to improve the structure in the brain and eyes. So again, further promoting the whole grain versus the refined grain. So examples of whole grains include bulgur, barley, farro, quinoa, millet, buckwheat, and even oatmeal. And you'll see that the ones I've asterisked, they are also plant-based sources of protein. So you cannot go wrong with any one of these choices, but the ones that I've asterisked, if you're looking to increase your protein, you can certainly look to add. So let's talk about legumes and beans now. There's a few different nutrients that are found in legumes that are going to help you stroke-proof your life. First is folate. And folate is required for red blood cell production, and it's necessary for cell growth. But what I do want to highlight here is that folate helps to reduce the amount of a substance that is directly correlated to cardiovascular disease risk. So beans offer a very, very good source of folate. Now, iron is involved in oxygen transportation. It's a part of your blood. And we cannot breathe or live without oxygen, right? So you can see how important it is to have iron in terms of brain health. If we're not getting oxygen to that brain, we're having a stroke, and we're risking a lot of issues with that. So this is a good alternative to animal-based products because animals have a lot of iron. But if we're trying to reduce our animal product intake, then we can look to legumes and beans. Calcium, needed for bone health and proper heart function. Calcium is involved in your heart beating. So if we're not getting enough or we're getting irregular intake, that can also affect the heart. I'm sure you're probably familiar with dairy, right? And getting your calcium from dairy. But beans and legumes are also a really great way to get calcium from a plant-based source. And lastly, I've got magnesium here. It helps your insulin in your body work better, and it helps to reduce your blood pressure by dilating those blood vessels. So lots of great benefits here with those beans. Again, this is recommended to be consumed daily. Examples include chickpeas, beans, lentils of a variety of colors, edamame, peas, and any kind of bean. Black beans, cannellini, pinto, any kind of bean is better than none. Okay, questions? No? Oh.
Is soy milk a good source of absorbing foods?
So the question is if soybeans are a good source of like protein or
Calcium.
Oh, calcium, yes. So soy milk and soybeans are great sources of calcium and protein as well. So if you're looking to, again, have more plant-based sources of those nutrients, soy milk is a good option.
Yeah, another question. When we talk about eating foods, we are suggested to have 3 to 4 portions, servings of food, right? How much is a serving?
So a serving of fruits and vegetables, so fruit would be like a small apple the size of a baseball. Same thing with an orange. Or it would be about 15 or so grapes. A cup of berries, any kind, is typically a serving. Now with vegetables, 1 cup raw or a ½ cup cooked is considered a serving. So if you have, and we'll get to this later, I have an example, but imagine like half of your plate is typically going to be a serving to 2 servings of vegetables. But I do have an example later. Does that help? Okay. Other question? Sure.
Is it better to have the cooked or raw vegetables?
So the question here is if it's better to have cooked or raw vegetables. There really is no benefit in terms of if it's raw or if it's cooked. They're still going to contain that fiber. When you cook a vegetable, you're breaking down that fiber. So it makes it easier to digest. So in that sense, there's a benefit if you have any tummy issues, digestive issues, but in general, raw and cooked are perfectly okay.
We have one question over here.
Yeah, I have a question. There's a brand of bread that's sold in any major grocery store chain and sold frozen. And it's the Food for Life Ezekiel 4:9 bread. Are you familiar with it? Do you have an opinion on it? Because it tends to be more expensive.
Yes, so I have not heard of that specific brand, but I do have another brand. It's called Dave's Killer Bread. I don't know if anyone's heard of it, but I've looked at it and I have personally bought it myself. But when I looked at that particular brand and let's just say a Sara Lee brand, I was actually quite shocked because the Dave's Killer Bread, while it does have whole grains, it's got fiber, it also had 5 grams of added sugar, which is about a teaspoon and a half. Versus the Sara Lee brand that I was looking at had 0 added sugar and less calories per slice. So it really just depends on what you're looking for. Are you looking for more nutrient-based breads or are you looking for less added sugar? It's very hard to find something that offers all of it. Does that help? Okay, great.
I have a question.
Sure.
In regards to the bread, is sourdough bread that's slow fermented, she makes it, this lady makes it, healthier than store-bought
So the question is if sourdough bread in general is better than the store-bought. Is that correct? Okay. So sourdough bread is fermented. So it has that prebiotic, probiotic kind of profile that's helpful for the gut health. Okay. But sourdough and regular bread, it's still a carbohydrate. It still has calories. So regardless if you get a store-bought or if you make it on your own, it's still going to be a grain or carb. So there's the added benefit with the sourdough for the prebiotic and probiotic, but they're gonna be essentially the same in terms of calories typically. Other questions?
Is it okay to eat beans in a can?
So the question is if it's okay to eat beans in a can. So beans in a can will have more salt typically, right? Because they're canned. And salt acts as a preservative. So I encourage people to have canned beans because it's convenient. But you want to make sure you're buying the very light or light and or no salt added canned beans. You do not want to buy the reduced because the reduced salt only means it's going to be reduced by 25%. So if it's 1,000 milligrams, 25%, you're still going to have 750 milligrams in that can, which is still a lot. So very light or light. Other questions? Good questions.
Please call me if you have questions. The reason is this is connected to our speakers and that is connected to our recording. Even though you think your voice is loud, it's not loud enough.
When we talk about bread, now we have multi-grain, whole wheat, and sourdough. So which one is healthier?
So bread in all of its kinds can be a part of a healthy diet. I would say that if you're looking to have a healthier bread, you want to search for one that is whole grain, whole wheat, multi-grain. Because remember that slide that I had? Oops, right here. That refined grain, like a white bread, white pasta, things like that, they're refined. There's no good stuff in there. It's just the starch, which is still necessary. But the whole grain, so like your multi-grain, your whole wheat, your sourdough isn't always a whole grain, but we want to go with the whole grain option, which again, all of those that you listed are going to be good options. You can't go wrong with either one. Okay, so now let's talk about the fats. There's two kinds of fats. There's saturated fat and unsaturated fat. So the saturated fats are solid at room temperature. So think your butter, your lard, bacon fat. It's liquid when you cook it, but what happens when you kind of leave it there? It hardens, meaning you can't see through it. So that's how you can identify a saturated source of fat. And saturated fats increase your LDL cholesterol, remember that trash, and it does increase that HDL just a tiny bit, but not a lot. And if we look at the unsaturated fats now, these are liquid at room temperature. So think your olive oil, canola oil, soybean oil, things like that. These types of fats are beneficial for your heart because they take out that bad LDL cholesterol and they increase your good cholesterol. So again, examples of these guys are going to be olive oil, canola oil, your corn oil, cottonseed oil, etc. And I briefly mentioned omega-3 fatty acids earlier on when we talked about the whole grains. And omega-3 fatty acids are seen as anti-inflammatory. And we need to get these through our diet because our bodies really cannot make them on their own. So we get them through fatty fish like salmon, herring, anchovies, chia seeds, and flax seeds. But I'm sure you've also heard about omega-6 fatty acids. And these foods like walnuts, hemp seeds, a lot of the oils I just mentioned, tofu, are higher in omega-6s. I'm sure you've probably heard that omega-6s are not great and that we should avoid certain oils. But why are they deemed so bad? Let's find out. So the Western diet is typically going to be higher in omega-6 fatty acids because in those processed, refined products, they're adding a lot of those oils that are higher in omega-6s. So as a society, we're generally consuming these omega-6s in excess. So that's why we see more inflammation. But that doesn't mean omega-6s in general are bad, because as you saw, walnuts, hemp seeds, all these oils are still considered the healthy types of oils. So the omega-6s get their bad name because we use them in a lot of refined and processed products that we do consume a lot of. So just to put it into perspective here, there's a few different nuts listed here. Almonds, cashews, we've got walnuts, and you'll see that they are all fairly low in saturated fat. Of course, they do have some, but not a lot. The rest are the unsaturated, the omega-3s, and there are a few that have some omega-6s. So in general, you still can have nuts in this diet, in this Mediterranean lifestyle. We encourage it, but this is just going to show you that it's mostly the good types of fats that are coming from nuts. Same thing with the different oils. In the blue, that's the saturated fat. So your coconut oil, your butter fat, beef tallow, things like that are higher in the bad fats. So we want to avoid those. And then you'll see the soybean, the peanut, the flaxseed, the olive oil. Those are going to be better since they are higher in those omega-3s, in the mono and poly unsaturated, which are the heart healthy ones. All right, questions about that? No? Okay, sure.
What about peanut butter?
So peanut butter, she's asking about peanut butter, if it's healthy, correct? Okay, so peanut butter is going to be healthy. It's more unsaturated. Of course, every food will have a little bit of that bad fat, but it's generally considered a higher source in those poly and mono unsaturated. So definitely still an option here. So let's talk a little bit about protein now. So in the Mediterranean diet lifestyle, we are focusing on plant-based sources of protein, but you can certainly still include fatty fish. You can include low-fat dairy products and lean cuts of meat if you still want to. Protein is important, especially as we age, because we lose muscle and we tend to keep on fat. But muscle helps us function. It helps preserve our quality of life. So protein from these various sources are important. But if we're trying to implement more of that Mediterranean diet, we want to focus on that protein from whole grains, legumes, the lentils, the nuts, and the seeds. So let's talk about the wine, right? The wine. So there is conflicting data. Some data says, yes, it's helpful. Some data says, no, it's not helpful. So where does that put us? The World Health Organization says that there's no safe amount of alcohol to drink because it is a toxin in our body. Our body does not like alcohol, although it may be fun, right? It does not like it in the body. So ultimately here, if you do like wine and you already drink alcohol, you can have 3.5 ounce glass, 1 for women a day and 2 for men. But if you don't drink alcohol, don't start. Same thing with like the tobacco the ladies were mentioning. If you smoke, try to stop. If you don't smoke, do not start, okay? So wine can absolutely still be included, but it's not something you have to go out of your way to add. I would much rather you go with the beans and the whole grains rather than starting with the wine, okay? So what I want you guys to leave with today is how to implement the Mediterranean diet today. Well, maybe not today if you haven't had dinner yet, but maybe tomorrow, okay? Start tomorrow. So I have an example here for you. Let's say that you have a plate of pasta with a marinara sauce and a breadstick and a 12-ounce can of Pepsi. Learning what we did today, how can we turn this into a stroke-proof meal? Don't eat it. Well, we certainly still can eat it in moderation, right? But what can we do if, let's say this is being served somewhere, to change that around? And feel free to shout out some answers.
Whole wheat pasta.
Whole wheat pasta. I like it. What else? Remove the soda pop. Mm-hmm. Yup. What else? Add veggies in the pasta. Absolutely. What else? Get rid of the breadstick, I would agree, but we're missing something. Protein, absolutely. So you'll see on this picture here, much different than what I have on this first slide. The pasta portion is significantly reduced. So instead of having a whole plate of pasta, only a quarter of our plate is filled with that whole grain pasta, hopefully. I've added the olive oil. So we've taken away the marinara sauce and we've added the olive oil. We've also added protein, which we did not see on this slide. So we've added fish, but you can certainly add chicken without the skin. If you like beef, you can have beef, but in moderation. So we've added fish here. We've also added the vegetable because there was none here. We have the lettuce, tomatoes, onions. We've got cucumbers on there, more color. And we've also swapped out that sugar-sweetened beverage for water and a glass of wine, depending on your preferences. But you see, we've taken this and we have now created balance. We've added color and we've taken away a lot of the added sugar that helps to clog your arteries, which we don't want. So again, replace the sodas and other sweetened beverages with water. Water is king. Add nuts and seeds to your yogurt and your salads. Dress it up. It doesn't have to be boring. Instead of those refined grains, choose your quinoa. Choose brown rice instead. Choose barley. Maybe even experiment and try farro, because nobody knows about that one. Olive oil, much better than butter. So whenever possible, make that swap. Have a meatless Monday. If you're feeling crazy, take all the meat out in your meals and replace it with tofu or beans. You can invite a friend to cook together. A lot of people after COVID, we don't have that social interaction, but that's so big in the Mediterranean diet. Take a walk after a meal. Helps your blood sugar too. So movement is a part of this lifestyle. So with that being said, your key takeaways. Think of this Mediterranean diet not as a diet. Think of it as a lifestyle. And it's not something that you have to have rules to follow. You can choose one thing from whatever you learned today and start doing it, maybe today, but hopefully tomorrow. Prioritizing water as your main fluid. And no matter where you are, you can implement the Mediterranean diet. If you're at work, if you're at school, if you're at home or at a friend's house, these things are things you can do on a daily basis. It just takes one simple change. So with that being said, I mean, I know you guys have had some questions, but I'd love to hear more. Sure.
What about dessert?
Say that one more time.
Dessert?
Oh, dessert. So desserts tend to be higher in calories, higher in those bad fats. So in moderation, okay? So for example, sometimes what I like to recommend to my patients, take a banana, right? That's a fruit, and make it into like a sundae, like banana split. You can still add a little bit of chocolate, maybe you throw on some peanut butter or Greek yogurt, add some nuts, and there you have a dessert that's not really, that high in calories and high in the bad fats that we don't want.
Now, sometimes when you're taking a trip and you're doing long distance driving, the only thing you see off the highways are the fast food restaurants.
Yes, unfortunately,
So you have to
yes.
stop at a major fast food restaurant chain and pick a food item that was the healthiest, which would it be for you?
Oh gosh. I mean, I hate to say Chipotle or like a Panera, but I would say those would be a better option because they do offer those beans, legumes, the salad, the corn, things like that. But I have found that they are also fairly high in salt. So that's another thing. You're really never gonna find like that perfect ideal food when you're eating out or even buying like new products at the grocery store. But if I were to choose, I would probably stream that way, or like a Naf grill. I've recently gotten into that. It's very Mediterranean and focusing on those fruits and vegetables.
So continuing on that stream, if eating out is not too much of an option, what will you carry?
So if I'm understanding your question correctly, if you are not eating out, right, if there's nothing around, what would I carry? Okay, so one of my favorite snack options right now is edamame. So edamame, you can either like buy it at the store and kind of spice it up on your own with your own like flavorings and seasonings, but they also have a brand called, I think it's Only Bean. They make like little travel size packs. They've got like 7 grams of fiber, it's only 110 calories, and I wanna say 12 grams of protein, which is from plants. So super, super nice snack that's non-perishable. You can take with you on a plane, you can take with you on a car ride. So I'm a really big fan of edamame right now, but you could do trail mix, right? Have some nuts, maybe some dried fruit, add in maybe a few M&Ms if you want, but that could also be a great option. Other questions?
Any other questions before we find out then? Just a moment.
Do you recommend taking any type of supplements or vitamins to go with your diet, Mediterranean?
Yeah, so the question here is if there's any specific supplements that will help implement the Mediterranean diet. No supplement will outdo a well-balanced diet, unfortunately, right? A lot of us are looking for supplements to kind of either ease that transition or help us increase those fruits and vegetables or those nutrients that come from those. But the best way to get those is through the actual solid food, right? No supplement is gonna, balance that out. A multivitamin though, I think can be super helpful, especially like vitamin D, omega-3 fatty acids, since we do need those because our bodies can only make so much vitamin D from the sun. We live in the Midwest. And then the omega-3s, again, we can't make them. So fatty fish, if we're still including that in the Mediterranean diet, great. But if we're not, we need a supplement. Good questions. These are good.
First question is, I got a feeling that both of us are already on some form of statin. So once we have that, then we can be a little bit more liberal on saturated fat, cholesterol. That's the first question. Second one is on oatmeal. How can you incorporate oatmeal into statin?
Absolutely. So in terms of the statin, just because you're on a statin doesn't mean that we can completely kind of like let go and kind of eat whatever we want. But I think that there does, it offers a little bit of flexibility. So regardless if you're on a statin or not, we want to be focusing on those heart healthy fats. So of course, if you go out to eat here and there, maybe once, twice a week, okay, great. But then how are we going to help increase those good types of fats? Right? I think it's all about balance. It's not about cutting out or completely taking out the, the bad fats that we all like, right? They taste good. But it's really about that moderation with all the fats. Now the oatmeal is a whole grain and it does have some protein. So right now, a lot of people like overnight oats because you can soak them, you can put yogurt in there, you can put nuts, you can put fruit. So I think oatmeal can be a very versatile morning, like breakfast option, but it can also be used as a dessert. Now I don't have a good recipe off the top of my head, but I've had patients who like to like add an egg, they add some chocolate chips, and then they bake it. And then they have like little granola bars that are made from oatmeal that you can have for breakfast, you can have it as a snack, you can have it as a dessert. So it really is a versatile option.
Okay, you have other question, just last question for the evening?
I got this one. Do you still follow the DV?
Say that one more time.
Do you still follow the daily value for protein, saturated fat, that kind of stuff?
Do I follow it?
And this kind of stuff.
Absolutely.
Second question is, legume and beans are extremely hard to cook, and then you still will not produce as much gas. So is there a trick to that, or what is the top secret in that?
So going back to the canned bean question. So canned beans I like because they're already kind of soaked, right? I don't recommend buying the dry ones unless you are a cook, but I'm not that great of a cook myself. I like the canned options because they've been soaked, so that fiber has been broken down a little bit. With beans and any kind of fiber, whether it's from fruits, vegetables, the key is to be slow. Okay, don't start eating a lot of beans all at once. The body does not like it, okay? So if you're starting to incorporate it in your diet, start with a serving, like a half a cup, and then see how your body does, and then go from there. Water intake is super important with fiber, like bean intake, fruits and vegetables, because one without the other really doesn't work. So I would advise smaller portions and water intake with that meal to help with the digestion.